Ladies and gentlemen, welcome to the Italian Cultural Institute for tonight's presentation, Diabetes 2011, Can We Cure It? To moderate the presentation, we have Dr. Pannain.
The topic of the lectures today will be the new technologies and treatments for diabetes that can or could improve quality of life for diabetics, even possibly lead to remission from the disease. The novel treatments that you're going to hear about may be already standard of care or still experimental, but I think carry a promise of changing the way we will treat type 1 diabetes, with juvenile diabetes, and type 2 diabetes, which is more the adult onset diabetes. So we have three expert speakers, Dr. Grazia Aleppo from Northwestern University in Chicago. She will talk to us about the new technologies for the patient with type 1 and type 2 diabetes. Then we have Dr. Benedetti from University of Illinois in Chicago. He will share with us the state of art of transplant in type 1 diabetes. Finally, Dr. Rubino, Francesco Rubino from Weill Cornell College of Medicine in New York will tell us about a new surgery, the metabolic and diabetes surgery.
My job tonight is to talk about what's available today for the therapy of type 1, type 2 diabetes that's more pertinent to technology, more gadget-wise. So as you know, I'll talk about these few things today: statistical diabetes, pump therapy, continuous glucose monitoring therapy, and the closed loop. So you know that it's really a huge issue, diabetes, right now in the United States. This pertains to all type of diabetes, 1 and 2. Remember that type 1 is only a very small percentage of the whole diabetes population. But you have already more than 25 million people today in this country, as of January 2011, with diabetes. And of them, on top of them, there's about 7 million who don't know who have diabetes, and 79 million people who have pre-diabetes, so they will develop diabetes most likely in the following 5 years. So it's a pretty big number. The closed loop, what is it? We're almost there. It's basically a tool where you have usually a pump, a sensor, and a computer system that puts the two things together without the intervention of the human beings. And this is what it looks like. You have the person with the two pumps with two different kinds of hormones, insulin and glucagon, the monitor, and the computer. The only issue that we have right now, and I'll make it short so I don't go over, is that, so the assistant uses it right now, is that right now the problem is you cannot do it independently. There is always a human being in the background that is pushing the button to activate the system. And so far, the couple of papers that came out show that what is the tricky part is really to have better insulin, faster, working better, and better tools that understand how to intervene in terms of the blood sugar fluctuation rather than just causing highs and lows. So this one paper, the last couple of slides left, shows that if you use a full closed loop without the person intervening right now, it will cause higher blood sugars and lower blood sugars. If you use a mix, it's called the hybrid, where the person with diabetes takes some insulin before the machine takes over, there's a better control. That is the one thing that's right now stopping us from being completely successful with this closed loop system.
The sickest one, the type 1. For your information, there are two types, and the juvenile diabetes, type 1, are people that for various reasons, mostly autoimmune disease, cannot produce insulin at all. All their islets, which is the functional unit in the pancreas that produce insulin, have been destroyed. As opposed to type 2, where there's still production of insulin, but the body cannot use it appropriately. Now, this is a slide that shows you what's happened to people when they start dialysis. Doesn't matter which kind of dialysis you do, in 5 years you have about 30% survival. Now, if you get a transplant, you have a better chance. Now, diabetic in particular are here, meaning a 5-year survival on dialysis of diabetic is 20%, worse than many cancers. So for a diabetic patient going on dialysis, a life sentence. Most of them die. It's even more tragic in Illinois, where actually the waiting time to a kidney transplant is approximately 5 years. Well, the transplantation of the entire organ has been started many years ago in Minneapolis, Minnesota, by Dr. Kelly and Lilai, and consists in transplanting the entire organ with a piece of duodenum, either drained into the bowel or into the bladder. Now, by transplanting the entire pancreas, you pretty much replace completely the machinery that is so perfect in keeping the sugar into very narrow range. No machine has been able to do what the human pancreas can do. Perfect control of the sugar all day long, without anybody checking on you, without computing. We actually have been able even to do the same operation using living donor. At the University of Illinois, we have a series of 15 of these cases, where a donor may donate part of the pancreas, one of the kidney, and pretty much cure at one time the diabetes and the renal failure. And again, I want to stress that for diabetic on dialysis, the kidney transplant is a life-saving. Although I will show you that transplanting the pancreas adds, besides quality of life, in survival. So, when we do pancreas transplant, in 3 situations, if a diabetic patient, again, usually a young individual that cannot produce any insulin, this doesn't apply well to the future. Of course, you can have a type 1 diabetic patient that had already have a kidney transplant, and it's relatively easy to go back and add the pancreas because the patient is already immunosuppressed. Therefore, you can take it without additional downside the new transplant. Finally, for some selected patients with type 1, we do isolated pancreas transplant. The main indication for that, as Grazia mentioned, is actually hypoglycemic unawareness, meaning people that do not feel the sugar go down. And of course, if they're driving or if they're doing something dangerous, can be fatal. And that's when we intervene and with the transplant.
But I want to finish this presentation in trying to tell you why I agree with this title, that surgery might potentially spell the end of diabetes, or at least the end of diabetes the way we know it. And the reason is because if you go straight, if you consider that what we are doing is we are not operating on the pancreas, we're not operating on the adipocytes, on the liver, on the muscles, which are considered to be organs involved in diabetes. We're simply operating on the gastrointestinal tract, the stomach, and on the small bowel. It happens that this organ, the gastrointestinal tract, is not a conduit for nutrients alone. It's more than just that. It's a true endocrine organ, and is indeed the most important endocrine organ in our body. It produces many hormones and substances, like about 100 between hormones and different signals, that regulate appetite, body weight, insulin secretion, insulin action, and many other things that are involved in the regulation of blood sugar levels. So it should not surprise that if you change the anatomy of that organ, you have an effect on diabetes. So this provides an opportunity for future new operations, novel operations, but also for endoluminal, like endoscopic procedures that could also be applied to treat diabetes, and even more so, the possibility to develop new drugs. And finally, I would say the very last slide that I would like to present you and provoke you with is that, sure, if the gut and the stomachs are endocrine organs, we can leverage on those on that physiology and try to treat diabetes, but we can also speculate that if there is an endocrine organ, just like any other endocrine organ of the body, it might get sick. And if an endocrine, it would be the only exception to the rule if the gut were perfectly functioning for all, in everybody, forever. So if the gut doesn't work, what would you predict based on the physiology of the gastrointestinal tract? You would predict that you're going to have alterations of body weight regulation, alterations of glucose homeostasis. In other words, it might be the gut, a site where to look at for us to try and find the cause of obesity and diabetes. And this is one of the hypotheses we're working on, and I think it's a very fascinating hypothesis that might change the way we think of diabetes, the way we treat diabetes, and hopefully the way we prevent diabetes in the future. Thank you very much.